be done. So we'll start out with a quick case. This is a 25-year-old male who comes in with shoulder pain in his right shoulder that began 4 years ago while he was a college baseball player. Pain developed gradually. Conservative treatment helped somewhat, but he still experiences pain with overhead motion, throwing activities. He's still trying to throw the ball around with his buddies, and it's bothering him when he's playing around. On exam, he has normal BMI, no asymmetry, pretty much normal range of motion, full strength. He does have some mild apprehension anteriorly. He has a positive O'Brien's speeds test. His radiographs are pretty unremarkable. So after some physical therapy, he ended up getting an MRI. And we'll talk a little bit about MRI findings in a slap tear. But what you can see is a little bit of signal. This is an arthrogram, a little bit of signal getting superiorly, undermining that superior labrum there. So he was diagnosed with a type 2 slap tear. So would anyone in the audience just quickly say what they may end up doing for this patient after exhausting non-operative management? And then maybe contrast that with if they were a laborer versus an elite athlete or an elite pitcher.
So at 25 and post-collegiate baseball pitching, if you really did exhaust everything, then surgery would probably be a biceps tenodesis. If it was a laborer, same thing. Elite pitcher, I'm still not sure what the answer is, so I'm waiting for you to give me the answer. But I don't think anyone's sure of the answer. So,
all right, stay tuned. So slap repair in the U.S. suddenly exploded around 2002. In New York City, the volume of slap repair increased by 464% in an 8-year period. And then nationwide, the amount of slap repairs pretty much doubled from 2009, from 2004 to 2009. This has since declined significantly. When slap repair was first introduced, nearly 70% of patients with slap tears had them repaired. Well, now it's less than 10%. And it's largely due to a growing increase in biceps tenodesis to treat slap tears. It was not commonly done at all prior to 2003, but it's now the most popular procedure done for an isolated slap tear. And I think it's important to note that while there are multiple surgical options, there may not be one procedure that's universal for all patients. And we'll get into how a 50-year-old sedentary patient is different than a 25-year-old who's different than a throwing athlete or a regular athlete, and especially a pitcher. So this significant difference in patient characteristics makes it kind of hard to pool the literature of what we have and extrapolate data to fit each unique patient. So some believe that the biceps tendon plays an integral part in throwing athletes' mechanics and performance, which would be compromised if a biceps tenotomy or tenodesis is done. Slap tears were first described by James Andrews in 1985. The original thought was that during follow-through of an overhead athlete, the elbow is rapidly extending and the biceps exerting an oppositional force to try and decelerate this rapid extension. And that force is transmitted proximally and through the long head tendon, lifting the labrum off the glenoid rim. And repeated microtrauma in this fashion was thought to be the cause of the slap. Morgan and Burkhardt proposed a different mechanism during late cocking in a thrower's motion, the abduction external rotation position. The biceps tendon exerts a torsional force on the superior labrum. Seen here in this figure, at maximum abduction external rotation, the repetitive shearing stress in throwers peels back that superior labrum. It's also probably part of a disease spectrum of internal impingement or glenohumeral internal rotation deficit. Throwing athletes over time develop extreme amounts of external rotation flexibility in order to maximize their throwing force. And this external rotation gain is frequently associated with loss of internal rotation and posterior capsular tightness. And I can even, for the people in the room, can demonstrate you don't need to be an elite athlete. You can be a failed D3 pitcher. And my external rotation is significantly more than the contralateral side. And I have very little internal rotation. So that's common in throwing athletes. That leads to posterior capsular tightness, which can bring the humeral head in a slightly superior and posterior position on the glenoid, which can result in the articular side of the rotator cuff and the superior labrum be pinched between the bony surfaces, resulting in these tears. It's why articular sided cuff tears can commonly be seen with slap tears. So patients with GERD, you want to treat them with aggressive posterior capsular stretching, seen that sleeper stretch at the bottom of the slide. So I think realistically, slap tears are probably a result of all three of these mechanisms. So that kind of begs the question: do you want to sacrifice the tendon, or do you think that it is contributing in some way or another to the throwing athlete's mechanics? I think that is yet to be determined. The Snyder classification is informative, but not too relevant to this discussion, because for the most part, athletes and throwers, they're going to end up with type 2 slap tears. So that's here in the top right of this slide, where that biceps anchor is just lifted off the glenoid. There are other types of slaps, but we're not going to talk about all types of slaps today. We're going to focus mostly on type 2 slaps. So diagnosing a slap tear can be pretty tricky for multiple reasons. They can be acute traumatic injuries, or they can just present as a slowly progressive shoulder pain, loss of velocity or command on the pitcher's mound. And there's no single maneuver that can rule in or rule out a slap tear. The O'Brien's test, crank test, Speed's test are the most accurate. O'Brien's test is a good test to begin with because it's a little bit more sensitive, and the crank and speed tests are a little bit more specific. Literature talks about the 3-pack test, which combines O'Brien test and pain with throwing with bicipital groove tenderness. But the bottom line is that there's really no single maneuver to rule in or rule out a slap tear, and imaging should be obtained if there's a high clinical suspicion.
Jim, why do you think Speed's test even comes into the discussion?
I think it's just your biceps, the inflammation of the biceps. I think it's a spectrum. It's not just a labral pathology. It's the whole biceps anchor.
Because I think mechanistically, the Speed shouldn't really stress the biceps anchor, but might tell you if you have biceps pathology.
So, should always start with X-rays. There's no, pathognomonic signs on an X-ray for a slap tear, but throwers can develop some retroversion of the glenoid and the humeral head. So it's something to keep in mind, and you may see a Bennett's lesion, which is shown here on this slide, which is just a calcification of the posterior IGHL after chronic strains from the deceleration phase of throwing. An MRI, this is a normal MRI, just so that we can know what to compare it to. You can see with those double arrows that undercutting of the cartilage going medially. So that's not to be confused with a slap tear. That's the normal cartilage. And you want to also not be fooled by a sublabral foramen on your axial cuts. This type 1 slap, I just put in here just to compare it. You'll see some fraying, and you see the undercutting going medially, but that fraying is kind of separate from that normal cartilage signal. The type 2 slap, you'll see that normal undercutting going medially, and then that vertical line where that signal is getting in between the labrum and the actual glenoid itself. The other thing to look out for on your MRI is if there's a paralabral cyst. So a chronic cyst, depending on the location, may be compressing the suprascapular nerve and may result in some weakness in your patient. It's important to try and parse that out. And if you do see a cyst, you should be very suspicious for labral pathology. So talking about that's a normal MRI, and you should order an MRI if you're worried about a slap tear. But the problem is that normal in a throwing athlete may be completely abnormal. The Miami Marlins looked at 21 asymptomatic professional baseball pitchers over a 10-year period, found that more than half of them had rotator cuff tears, more than half of them had slap tears, And pathology was seen at a higher rate with higher innings pitched. So it's probable that this is likely due to their pitching activities. Again, these people were totally asymptomatic. So not only that, there was no correlation with the pathology seen here and any subsequent time on the disabled list. So this, it's not like these were these injuries were before it actually developed. The people with the rotator cuff tears, slap tears, did not result in any time lost. So this demonstrates that throwers will usually have an abnormal MRI more often than not, especially with higher volumes of pitches thrown. And it's it's probably because minor labral and cuff injuries can increase shoulder mobility, which will allow for a greater external rotation and humeral torque, which could possibly improve performance. So slap tears come in two flavors. Some talk about a good slap and a bad slap. Another way to frame it is an adaptive slap or a pathologic slap. And as mentioned, throwers commonly have shoulder pathology on MRI and may be completely asymptomatic. So the thought is that these patients have developed these lesions as a way to paradoxically improve their performance by increasing range of motion and torque. So this is a good slap or an adaptive slap. You obviously don't want to operate on these and take away all of those gains in range of motion that they've developed. And then there are patients who have slap lesions that may look identical in imaging or grossly to the patients who are asymptomatic, and they need to be addressed one way or another. So these two patients may have completely similar pathology appearing on MRI or grossly, and one is completely debilitated and the other is not. So the bottom line here is to be careful who you order an MRI on, and then take your MRI findings with a grain of salt in a thrower, because the slap tear that you find may not be the actual cause of that patient's pain. And fixing a slap tear, if that's not actually the problem, may do more harm to the patient than good. So conservative treatment is the mainstay initially, partially to identify those who have a bad slap, and partially to avoid unnecessary operation. Initially, you're going to just do the usual rest anti-inflammatories, and then you want to evaluate a thrower specifically. You want to evaluate their mechanics, try and find any weaknesses in the kinetic chain that may be putting more strain on the shoulder. And multiple studies show that non-op treatment can improve the majority of patients, but nearly half will fail and require some sort of operation. You can offer things like a bicipital groove injection as well, just to see if that results in any sort of relief. I don't think our surgical success rate is high enough yet just to jump straight to surgery in anybody, but it'd be nice to identify who is at high risk for failure of non-op management, if anything, just to provide reasonable expectations to patients. This study from 2018 out of Japan looked at 45 baseball players from high school through the pros. The mean age was 21 years old. They looked to see who responded to therapy and who did not respond. And out of 45 patients, 32 of them returned to play with non-operative management at an average of 5 months. Failure of non-op treatment was seen in 2 patients who quit baseball, 4 returned but no longer could pitch, and 7 required surgery. This success rate is much higher than most of the other studies, but this study does provide some insight into who may fail non-op treatment. Odds ratio of failure is shown on the top of this slide, and you can see that age statistically correlated, significantly correlated with Bennett spur and articular sided tearing on imaging, and age and both of these imaging findings were correlated with failure of non-op treatment. Longer symptomatic period, longer duration of baseball experience increased your failure chances. Pitchers had a higher rate of failure to respond to trying to stretch out that internal rotation deficit at 2 months predicted failure, while those who improved their range of motion after 2 months showed a favorable response. So I think it would be reasonable to, based on this study, consider surgery on somebody whose internal rotation does not improve after 2 months, especially if they're older and have multiple risk factors seen here. So slop repair was initially introduced using metal staples or screws, bioabsorbable tacks, but loosening and breakage was unacceptably high. So now arthroscopic repair with suture anchors is the primary option. You want to, place your knots away from the glenoid, and newer knotless anchors are showing promise as well with less knot irritation. But where do you place these anchors? The location of the repair should be based on the pathophysiology. So a cadaveric study was done where 3 anchors were placed, and each suture range of motion was tested after the repair. Each suture was then sequentially released, and range of motion testing was done before and after as well. And they found that anchor anterior to the biceps results in significant reduction in external rotation. So that's why most people who fix slap tears, especially in throwers, will not put anything anterior to the labrum and mostly stick their anchors posterior to the labrum. Slap repairs in the general population has mixed results. Denard found 91% of the patients were satisfied and 82% could return to their prior level of activities. Workers' comp patients had significantly worse outcomes, and age over 40 was associated with worse outcomes, but not significant. Preventure did find a significant difference based on age. So he had similar results to Denard's study, but patients above 36 years old had a 3.45 relative risk for failure. And while some patients, particularly the younger patients, do pretty well, these are not throwing athletes, so it's difficult to extrapolate this to an athletic or throwing population. Rick Wright at WashU looked at a systematic review about 10 years ago, looking at 12 studies, following them for 2 years, isolated type 2 slaps. This is all level 3 and 4 evidence, but most of the patients were younger athletes, and the return to play ranged from 20 to 94%. So there's obviously a large range. In the general population, people did pretty well, but if you look specifically in baseball players, those results are down to 22, ranging from 22 to 64% returning to play. And a review out of Rothman 2 years later echoed this, and they found that 83% of athletes had good to excellent patient satisfaction, 73% return to play. But if you look specifically at overhead athletes, only 63% of those patients were coming back to play. So, the general population does better than overhead athletes, which does better than baseball players based on these studies at least. I think one important variable to not forget about is a concomitant injury. This cohort out of Curlin Job 10 years ago looked at 23 college and pro baseball players treated with slap repair at 38-month follow-up. According to the American Shoulder Elbow score, 96% had good to excellent scores, but the KJOC score was 42% good to excellent with 30% poor, and only 57% of these people returned to play. So that just kind of calls into question how accurate the American Shoulder Elbow score or any outcome score is. I think the more important thing, if you're trying to get somebody back to play, the metric that you want to look at is the return to play or return to previous level of play. So try not to get too bogged down with how these people do in terms of outcome scores, because they seen here are pretty variable. Also in this study, 35% of these patients had a small rotator cuff tear. And in the patients with cuff tears, only 12.5% of them returned to play, while 80% of those without cuff tears returned to play. And these are small cuff tears, like large cuff tears were excluded. Small cuff tears, like 10 to 30%, were just debrided, and those patients did not do well. James Andrews looked at 73 baseball players in a 2019 case series, all 12 months out from slap repair. The 68% of the players enrolled were pitchers. 83% of the players returned to play baseball, 80% of the pitchers, and 91% of position players. I think, like I said, return to play is a solid metric, but a more relevant metric when you're trying to get somebody back to their previous level is RTPP. So it's return to previous level of play. And, different studies have different ways to determine this. Some it's arbitrary, some is based on specific stats before and after. In this study, the overall return to previous level of play was only 60.3%. And in pitchers specifically, it was just a little bit more than half. The pitchers also had greater perceived shoulder and general health impairments compared to position players. This is a similar case series where they looked at 133 baseball players 2 years after slap repair, and only 62% returned to play. 59% of the pitchers returned, while 76% of the position players returned. Both groups had KJOC scores significantly lower than the minimum desired score for a healthy baseball player, but there were no significant differences between each group. This study was another MLB group looking at 24 of their players, all pitchers undergoing slap repair. Only 62% returned to play at all. And they found that barely more than half of the pitchers were getting back to their previous level. And the ones who actually did come back, the amount of innings pitched was pretty much cut in half. So, this begs the question: are we doing these pitchers any favor by saving their biceps tendon if we're doing it, to make sure that their throwing mechanics are maintained? So, as discussed, outcomes in baseball players and throwers are inferior to other athletes, and those with a traumatic etiology appear to do better than those who have overuse injuries, which makes sense because most of the pitchers are experiencing overuse injuries. So these two studies kind of highlight this fact. This top study by Brockmeyer, it's a prospective study of 47 patients after 2 years. 87% reported an excellent outcome. Satisfaction rating was 9 out of 10 overall. In those with a known traumatic etiology, the satisfaction was 9 out of 10 compared to 7 out of 10 satisfaction with those without a known trauma. So 92% of these patients with a traumatic event returned to their same pre-op level, compared to only 64% in the atraumatic group. And this next study, this case series below, kind of show the same thing, where 60% of baseball players are returning to their previous level of play, compared to 75% of other athletes. And then again, 75% of overuse injuries return to play, while 93% of the traumatic cases return to play. So if you're trying to find a group that specifically responds to slap repair, seems like those who had an actual traumatic event, they may be the ones who would benefit most from this surgery. So this is a great study done by Federo in 2014. They actually took patients from the beginning to the end, starting with non-operative management. They created a very specific return to play metric based on stats, and they stratified based on position players and pitchers. So 119 baseball players in the Houston Astros organization were evaluated for persistent shoulder pain that failed to respond to rehab on their own. They found 68 patients, 45 of them pitchers, found to have type 2 slap tears. All of them underwent non-surgical treatment initially, and failure to respond to 2 attempts at rehab was an indication for surgery. Return to play meant coming back and playing in 1 game the following season after spring training, and return to previous level was defined as playing for at least 1 year in the same league with similar stats. So position players overall returned to play 87% of the time, while only 57% of them returned to the previous level. 1 out of 4 patients was successfully managed non-operatively, returning to the previous level of play. And in those who failed non-op treatment, 85% came back to play, but only 54% were at their previous level. In pitchers, 62% came back to pitch in 1 game, but only 26% returned to their previous level. Non-operative treatment, again, worked slightly less than 1 out of 4 patients. And in pitchers who had failed non-operative treatment, operative treatment with a slap repair was wildly unsuccessful, with only 7% returning to their previous level. So you look at these outcomes side by side, the differences are pretty striking. We know that baseball players do worse overall. Seeing how much worse pitchers do compared to position players is pretty troubling. So, proponents, again, of slap repair believe that retaining the biceps tendon is crucial for throwing mechanics. You don't want to take the biceps tendon of a pitcher because you think their performance may struggle, but slap repair clearly not a highly successful procedure for these pitchers. So I think it's time to possibly look elsewhere. So just, in talking about slap repairs, like I was saying, the general population, people seem to do okay. It's dramatically better if there was a traumatic etiology. But in a throwing athlete, you're not, the results are not good, especially pitchers. So trying to figure out why these repairs fail, could be iatrogenic, not irritation. Placing your anchors anterior to the biceps tendon, just the nature of operating on a shoulder in general. And then we know that, even if you do a perfect surgery, pitchers are developing these adaptations in their range of motion. And if we, constrain the superior labrum and we take away their adaptive range of motion increases, that may set them up for inability to return to their previous level. The superior labrum is also largely avascular, seen here in this image from this cadaveric study. And the biceps tendon is highly innervated, so it's very easily irritated. And pain could be one of the reasons why these patients have a difficult time returning to play if you're not adjusting the biceps. So the thought behind a biceps tenodesis is that the biceps tendon is a major pain generator, and removing this, taking out that diseased tendon and reattaching it beneath the pec major is going to relieve pain, and it's going to avoid the stiffness that comes into play with a repair. Opponents of the biceps tenodesis claim losing the joint spanning stability of the biceps tendon can cause some issues. Thought that the biceps tendon can be crucial to throwing mechanics, stability. It was initially done as a salvage procedure in those who were looking for pain relief rather than functional improvement. But in military patients in a salvage setting, show that they have excellent outcome scores and good return to sport and active duty with a biceps tenodesis after a failed slap repair. So you're not really sacrificing functionality like people were once afraid of. So what exactly does the biceps tendon do for stability? There was a biomechanical study on 20 cadaveric shoulders showing that in patients with a slap tear, performing a biceps tenodesis does not further affect stability in any way. Repairing the slap did return the shoulder back to its initial stability, but in patients who have spent their whole baseball career trying to improve that range of motion and micro instability, that may not be such a good thing. So it may be a benefit that the biceps tenodesis doesn't restore the native stability, but that it doesn't further destabilize the shoulder in any way by taking the biceps tendon. In the general population, biceps tenodesis, works pretty well. Most patients are able to return to their previous level of activity, but given the hesitancy to perform this on throwers and younger people, there's pretty limited evidence to support its use. This prospective cohort of active recreational athletes, mean age was about 38. All athletes returned to their desired sport or activity level. There were significant post-op improvements and great satisfaction scores. They didn't comment specifically on throwers, but 70% of them returning to their previous level and 80% in overhead athletes. This is not necessarily the same trend that we saw with slap repairs. So again, one of the main hesitancies around biceps tenodesis and throwers is that it's going to affect their throwing mechanics, throwing motion. This was a controlled laboratory study out of AGSM in 2014 where they looked at 18 professional pitchers. There were 7 healthy controls, 6 were 1 year post-op from a slap repair, and 5 were 1 year post-op from a biceps tenodesis. And to be eligible from this study, all of these patients had painless shoulders, so they had a successful surgery. And they had no differences in range of motion. They underwent motion analysis and EMG studies. So there were no neuromuscular differences in any group. So you're not doing any sort of different muscular recruitment based on taking the biceps away. And in controls and biceps tenodesis, the peak in thoracic rotation occurred in the late cocking, early acceleration phase as the potential energy is being transmitted from the lower extremity through the thorax and into the humerus. While the slap repair patients showed that thoracic rotation didn't occur until late acceleration, where nearly 100% of the pitch has been completed already. So this can result in higher elbow valgus loads and can also result in a less efficient force transfer and decreased velocity. So, biceps tenodesis doesn't create the constraint and stiffness that a repair does. So it makes sense that you'd have a more natural throwing motion. So for those who, fear that changing mechanics with a tenodesis, it should be worth noting that biceps tenodesis patients, not the slap repair group, had mechanics more similar to the controls. This systematic review published last year from AJSM looks at 8 articles, looking at biceps tenodesis for overhead athletes, isolated slap tears. The outcome scores are all excellent, high satisfaction rates. Return to play was 70%. Again, these authors are cautioning against use in pitchers due to possible throwing mechanics issues, but that's just because there's really no evidence. This study published about 10 years ago by Below looked at his cohort of patients with isolated slap tears. It's not the best study, it's not randomized. He basically chose biceps tenodesis versus slap repair, usually based on age, which can confound his results. Pretty small sample size, but he had 9 out of 10 slap patients were athletes and 10 out of 15 biceps tenodesis patients are athletes. He found that the patients who underwent tenodesis returned to play at 87% compared to 20% in the repair counterparts, and 4 patients in the slap repair group were revised to a tenodesis, all of which returned to sport after that. Nearly all the biceps tenodesis patients were satisfied, while only 4 out of 10 repair patients were satisfied. They didn't really stratify this based on the sport type or throwing activity, but they did show that the tenodesis group had significantly higher satisfaction scores and return to previous sport level. Again, questioning if we're doing young people a favor by fixing their slap as opposed to just tenodesing the biceps. And again, this is not a great study, but this is the 8th most cited paper on slap tears as of this year. So it just kind of shows what little literature we have on the optimal treatment. So this study was interesting. It's a study published last year. It's a comparative study of 2 different surgeons who have differing opinions on the optimal treatment for slap tears. One routinely performs a biceps tenodesis and one does a slap tear on everybody. And they followed 53 of their patients and there were essentially no differences. So again, this could be completely biased because it's two different surgeons. But it's important to note that not all literature follows the same trend of biceps tenodesis patients doing better. Thankfully, there are some people out there doing biceps tenodesis on pitchers. There has not been a lot published. I mean, maybe that's in the works. This was just a abstract that I was able to find. You don't have the full manuscript, but this is 13 professional baseball pitchers who underwent biceps tenodesis for isolated slap tears, and 92% of them returned to play. Problem is, the more important metric is, returning to play. They didn't really specify what that means, if that's coming back for one pitch or if that's, returning to previous level of play. But I think the fact that this study is done may be nudging more people to possibly do this on a more younger athletic throwing population. When you're comparing a biceps tenodesis to a slap tear, there is, some consistency in larger pooled studies. This meta-analysis looked at 8 studies published in 2019. All were unfortunately deemed low quality studies, and the age was 31 to 65. So you can't really extrapolate this to athletes necessarily. But there were no differences in UCLA or SST scores between the 2 groups, but the tenodesis group did have significantly higher shoulder elbow scores and satisfaction scores. I think the main reasons why I'm including this study is just, looking at that odds ratio of satisfaction, which is, probably the more important patient reported outcome, being, 0.31 in favor of biceps tenodesis. So this meta-analysis published in the same year looked at less studies, but it did cover, specifically an athletic population of 204 patients. And they found, no significant differences in outcome scores, stiffness, or reoperation rate, but they did find significantly higher satisfaction and return to sport in the biceps tenodesis group. Again, not necessarily relevant to throwers, but those numbers are pretty striking. So, conclusion on biceps tenodesis is that, in the general population, people do pretty well with this operation. Some studies show no difference between this and doing a repair, but I think most of the studies, especially the larger studies, show that biceps tenodesis patients have higher satisfaction and return to sport rate. But the bottom line is that we just don't have the information on throwing athletes. So, kind of overall conclusions, slap tear remains a complex and unsolved problem in throwing athletes. You want to try and exhaust non-operative treatment, especially after seeing how poor our results are and getting pitchers back onto the field. You really want to try non-operative management first. The role of the biceps tendon in throwing is debatable, and the studies that I presented kind of calls that role into question. I think bottom line is that both of these are pretty safe procedures. The general population do okay with both of these operations. And, I think that traumatic injuries are ones who may be best fit for a slap repair. But I think the bottom line is, we need more studies. We especially need more studies on biceps tenodesis in throwers. I think it just is going to take some people to push the envelope to see if they'll do that. And I think that you see the trend that initially started was everyone was fixing every slap tear that they saw. And now they've moved on to biceps tenodesis. And I think we're just kind of lagging behind in the throwing athletes as well. So now the throwing athletes are still getting repaired. And I think it's time for that, paradigm shift to possibly look at taking their biceps and seeing how they do. But, having said all that, just kind of going back, is there anything that anyone would volunteer in terms of what for these 4 people, what they would prefer to do, what their treatment would be, and in, a normal person, 26-year-old who just kind of wants to toss a ball around with his buddies, a laborer, elite athlete versus an elite pitcher.
You can put me down for biceps tenodesis for everybody, Jimmy.
For me, on the first two, and I don't see elite athletes or pitchers, mostly people that don't throw. I think that defining where the problem is the biggest issue I have, whether it's in the bicipital groove and it's really tendonitis, or whether the pathology seen on MRI is really significant. So because the results can be crazy. I think differential injections either in the bicipital groove or the shoulder is very helpful, and in the bicipital groove with cortisone under ultrasound. And I think a tenotomy is an option for those people because the results in the literature are fairly similar, and it's a 5 or 10 minute case with almost no rehab. So I think that tenotomy or tenodesis, particularly in the non-elite athletes and certainly pitchers, in cases that really have symptoms emanating from either the slap or bicipital tendonitis in the groove.
Boy, I would very much echo that. I prefer a tenotomy over a tenodesis in a non-athlete. Now, for the young throwing athletes, sometimes, you've exhausted everything and they've done their therapy and you've got your MRI with or without dye, and there is maybe something going on. So for the few shoulders in the younger athlete that I've done, I've scoped them. I have one patient I can remember that actually ended up having sort of a larger bank art and needed it open. Well, could have done it arthroscopically, but ended up doing it open. But the majority of those were really more or less diagnostic scopes. Not much was done other than taking pictures to show, look, here's some, posterior impingement. This is what your shoulder looks like, when we rotate it up and out of the way, and you can sort of demonstrate where that kid's pathology is in an effort to sort of reinforce, mechanical changes, which doesn't always work. But it's been a difficult thing. I have not done a lot of tenotomies in younger athletes that are overhead throwing athletes. I would not be against doing that, but just don't have a lot of experience with it. So that's my 10 cents.
What's the difference though? What's the difference if it heals in the groove or it heals sub-pec? If the
I don't
problem
think
is,
there is a difference.
if the problem is truly related to the anchor and the true slap, if that's truly the problem, as long as you get that biceps out of the way, it doesn't matter where it goes. And if you take the biceps off as close to the labrum as possible, it's bulbous, 90% of them don't go into the arm and you don't get that, Popeye. I mean, people that do the tenodesis, everyone has to pull on that biceps to get it out unless you're cutting it, a centimeter or two more lateral. So it
I
stays
think
in.
some people worry about the biceps tendon still being there as a pain generator.
Well, then if if the problem is in the bicipital groove, that's a different story. If the problem is not in the bicipital groove, why do you think it would be a problem after you do the operation? So if you really think it's at the attachment site, then a tenotomy is a great operation. The problem is, as we get older, even if people think they're athletes, biceps tendonitis becomes more common. And, if the problem is really in the bicipital groove, then you have to take it out of the groove. That's why it's good to know ahead of time. And I just find that it's like impossible unless you do differential injections.
So here's another question to muddy the waters. So you decide the problem is at the attachment site and you do a bicep, you do whatever, some form of a biceps tenodesis because you don't think slap repairs work very well. Do you repair the labrum after you detach the biceps? Since they have a
If it's a
slap tear?
type 4, it depends on the size of the slab, right?
But I'm not talking about type 4, just straightforward standard type 2 slap. You have some detachment of the labrum posterior to the biceps, but you're not a fan of slap repair. So you do your tenodesis wherever you do it. It doesn't matter to me, but I want to know if you repair the labrum and why. Or why not?
I would not, unless it was like gross. Type 2s are usually, I've never seen one that was really unstable. So I would not.
You're removing the biceps to take the pull off of it. And now you're going to repair it. I don't know. Does anyone even have a study on that, Charlie?
Yeah,
No, people
there's
talk about it.
There's some studies.
Right. Everybody talks about it because nobody has the answer. But the question is how much stability you're talking about. Again, this elite pitcher who, every degree of external rotation matters. And if there's such a thing as posterior impingement, what's happening to that labrum. But, just because the anchor is off, does the superior posterior labrum provide any stability to the shoulder at all? Or is it just a part of the labrum that doesn't matter? We don't know.
I would not repair that. To me, the point of the superior labrum is the attachment of the biceps. And if that's off, then repairing that doesn't gain you anything.
Yeah, and I would echo that. I think that's part of the reason why elite overhead athletes don't do well with repairs is because their mechanics make it so that they're going to be impinging upon that typically anyway. So even if you've repaired it and you've rehabbed them properly, if they haven't changed their mechanics, which is really, really hard to do, they're going to be ending up in the same soup, whether you've repaired it or not.
I was at specialty day at the academy over the weekend, and Dugas and Andrews and Elatraj were there. They had a session on slap, and I left the session feeling like I knew nothing more than I knew when I walked in. Just the different opinions on what to do, and nobody really knows the right answer. I think one of the things, Jim, that you talked about was range of motion. Even pointed out your range of motion. So the pitchers have increased external rotation and decreased internal rotation, but it's not just their internal rotation loss, it's their total arc of motion, right? So you have to compare their total arc of motion to the contralateral shoulder. And it's the ones who lose, they all have an internal rotation deficit, but if that deficit starts to impinge on their total arc of motion, that puts them at a higher risk for development of a slap tear. And so you have to pay attention to that. And we've tried a couple of times, and you really work hard on posterior capsular stretching, which works in some people and gets them better. But if you ever have seen one of these shoulders where you go in, the posterior capsule generally is very thin. But when you see that, if you try to do a posterior capsule release, and I've done a few of them, that posterior superior capsule can be up to 1 centimeter thick. You can't believe how thick it gets. And we've tried in kids that aren't responding that well under ultrasound guidance. The primary docs at Rutgers are pretty good with ultrasound. Inject a little cortisone right into that posterior capsule, and that does seem to loosen them up a little bit, and that's helped. It's just anecdotal, but again, it depends on the level of picture you're dealing with. So I think you have to try hard with non-operative management in these patients. Just one other thing, I think, it seems like we're heading down the path of biceps tenodesis, even for pitchers. And if you look at the history of surgery in pitchers, it's going to take somebody really well-known who's going under surgery. Like Tommy John gets Tommy John now. Everyone does a Tommy John. Back in, in my fellowship days when Frank Jobe did the anterior capsule labral reconstruction on oral Hershiser, all of a sudden that operation became the thing to do. And now one of these days, some elite guy is going to get a biceps tenodesis and do really well. And they're going to say, that's the answer. But it's interesting how baseball has, in those three, we're on the third iteration of how do we keep elite pitchers on the mound. First it was elbow, then it was anterior instability, and now it's slap. So somebody famous will get one, then you'll probably be right, Jim. That's right.
I think baseball is different than football, but I think Andrew Luck had a slap repair and did not do well afterwards.
And John Elway ruptured his biceps tendon and won the
Not
Super
be out
Bowl.
himself.
So that everyone goes to John Elway and talks about how Elway ruptured his biceps, but a football pass is nothing like a baseball pitcher. I mean, not even close.
Jimmy, you're going to be in practice in 2 years. Who would you repair a slap on?
I think the only people I would consider a repair on is somebody in their, younger than 30 that had a traumatic injury where they said all their shoulder pain started after this one period of time. Then I would maybe repair that.
And do your best to do it acutely, not 7 months later.
Another thing I want to.
That traumatic injury has been described, and I've seen it where it really is a traction injury. It's like a rock climber who loses grip and grabs his body weight, sort of pulls his labrum off. I've seen those do well, those true traumatic ones. So I agree with that.
Another thing I just want to point out for the residents is Jimmy did a really nice job with his presentation. A lot of talking, pictures. There's not a ton of words on the screen. Right? That's a really nice presentation where you don't have to put every bit of detail on your PowerPoint slide. You can talk about it, have like a couple words at each bullet point. That's a well done kind of PowerPoint. If it's like the whole study up there, it's hard as the viewer to like figure out what the point of that is. And then your job as the presenter is to talk through that. So that's a really good take home when you're putting together presentations. That's kind of the goal when you're putting a talk like this together.
Yeah, don't read the slide to me. I can read.
This patient ended up getting a slap repair actually. I think he did pretty well, but it's probably because Dr. Gadd operated on him. That's why he did so well. So thanks for, especially for Dr. Gadd and Buckley, providing guidance on this talk. Thanks for listening.
But that is an older case, right? I mean,
that was back when everyone was doing.
Slap repairs, now fast forward, whatever it was, 10 years or how many years it was, probably be a little bit more reluctant to do a slap repair and do the biceps tenodesis. So.
Yeah, I wanted to echo what Pat said. Great presentation. I think it's a really good example for the residents or anyone listening, even if you're not going into sports, that everything you learn, everything you really focus on in fellowship, it's going to change. And slap tears are a very good example of that in terms of they evolved relatively quickly and things have changed and they are changing. So you'll see surgeons in the community who sort of go into their corner and don't pay attention to the literature and keep doing what they did for 35 years. And you really got to, not do that. Stay in tune. That's part of the reason we like teaching you guys. It forces us to keep learning and stay up to date with things that do change with evidence-based medicine. So thanks, Jimmy.
Go get a sunburn, Jimmy.
What?
Go get a sunburn. Have a nice trip. Good
Yeah.
job.
Thank you.